دكتورة منى ما قد قاعد شفتي هذا تعمل ريكوردينج. Should I start دكتورة منى؟
Go on دكتورة.
Okay. صباح الخير. I will talk about test for secondary hypertension. By definition, secondary hypertension is a hypertension due to identifiable cause, which may be treatable with an intervention specific to the cause. There are many clauses, which is in isolation or in combination, can suggest of secondary hypertension, such as the young age of onset of grade or 3 hypertension, less than 40, or sudden development of hypertension, or rapidly worsening blood pressure in elderly patients. Also, history of renal or urinary tract diseases. Use drugs such as substance abuse, concurrent therapies with corticosteroid, nasal vasoconstrictor, or chemotherapy. Also, repeated episodes of sweating, headache, anxiety, or palpitation suggest a few more chromocytoma. Any electrolyte disturbance with hypertension and maybe muscle weakness may maybe we should think about hyperaldosteronism. And also thyroid disease is a major cause of hypertension or pregnancy and contraceptive pills. History of sleep apnea. Regarding physical examination, we should be careful about it to search for secondary hypertension. Large kidneys is a sign of polycystic kidney, palpation, auscultation of heart and renal arteries, important for murmurs, which may indicate aortic coarctation or renovascular hypertension, and also a radiofemoral delay may be with the aortic coarctation, signs of Cushing disease or acromegaly, or sign of thyroid disease. Now we will talk about the cause and the prevalence and suggestive symptoms and screening investigation, starting by obstructive sleep apnea, which account about 5 to 10% of causes. Mostly patients it's OPs, and maybe present non-obese patient. He complaining of snoring, morning headache, daytime somnolence, and we can start screening investigation by a birth score and ambulatory polygraphy. Regarding renal parenchymal disease, which account to 2 to 10%, mostly patients they are asymptomatic. Most commonly diabetic patient may present with hematuria, proteinuria, anemia, and maybe there is a renal mass in adult polycystic kidneys. Regarding the screening investigation, we will start by plasma creatinine, electrolytes, estimated GFR, and we should search for protein and blood in urine, and of course, renal ultrasound. Renovascular disease, it's most common, and it's the most potentially correctable causes. It's divided to atherosclerotic renovascular disease and fibromuscular dysplasia, account for 1 to 10% of cases. In older patients with atherosclerotic disease, in elderly mostly, they also has widespread atherosclerosis such as coronary artery disease and peripheral vascular disease, and they may have diabetic, they have history of smoking, and they have recurrent attacks of flash pulmonary edema. For both, and fibromuscular dysplasia occurs more in younger patients and more common in women, and we can auscultate abdominal pruit. Also, the screening investigation for both are Doppler ultrasound, Doppler CT scan, angiography, or MRI. Sorry. Regarding endocrine causes, we have Cushing syndrome, which account for less than 1%. Most of patients may have signs of Cushing disease, such as moon face, central obesity, skin atrophy. The screening investigation of choice is 24-hour urinary free cortisol. Regarding thyroid gland, hyper or hypothyroidism, which account for 1 to 2% of the cases, we will find signs and symptoms of hyper or hypothyroidism, and we should do for them thyroid function test. Also, hyperparathyroidism can be a cause in less than 1% of the cases. Mostly they have hypercalcemia, hypophosphatemia, and we should screen by searching for parathyroid hormone and calcium levels. Now coming to the primary aldosteronism, which account for 5 to 15%, mostly patients becoming asymptomatic, but rarely muscle weakness. We should start by plasma aldosterone and renin level. Hypokalemia or electrolyte disturbance may occur in these patients. Pheochromocytoma, which has the role of PPs, paroxysmal hypertension, bounding headache, beating, palpitation, pallor, liable blood pressure. Also, the blood pressure may increase by using such drugs such as beta blocker or sympathomimetic opioids. And we should start screening by measuring the plasma or 24 urinary fractionated metanephrines.
Have you seen any pheochromocytoma cases? In your
Yes.
How many?
We had,
Yes.
well, we had, to me, it was one patient I saw.
One
It's
patient.
couples years. She was admitted with emergency hypertension.
How about Dr. Noor?
And she
Have you seen any?
Yes, one patient.
One patient. Dr. Mario, have you seen any?
No.
None. Dr. Ahmed, have you seen any?
يعني maybe 20, 25 cases. It's not very common, but we've seen because we're a tertiary center, so we've seen a lot of them. A lot of them can be adenomas. They're not always from actually the adrenal glands. They could be from the sympathetic ganglia across the spinal cord. There are different causes of pheochromocytoma. There is always this question, is it only the urinary or the plasma? Both can be used for diagnosis, and they are sensitive for diagnosis, of course, of pheochromocytoma. But it could be also a paraganglioma. It's not always restricted to the renal adrenal gland,
In
suprarenal.
20% of cases.
Yeah.
Okay, can I
In
continue?
Tunisia, we send them in the
Sorry.
Department of Endocrinology. It's not in cardiology. We don't see them in cardiology.
Yes, please continue.
Okay. Coming to the cortication of aorta, which account for about less than 1%, usually detected in children or adolescents. There is difference in blood pressure, about 20 or 10 millimeter mercury between upper and lower extremities, and between the right and femoral and femoral pulsation, low ankle brachial index. Screening investigation for this patient started with echocardiogram. Okay. Coming to the medication substance, we should not forget about to ask the patient of the using any part of this drugs, such as oral contraceptives, especially estrogen, which estrogen containing, cause hypertension in about 5% of women, usually mild but can be severe, and it's corrected by stopping contraceptive pills. Also diet pills, which is commonly used these days, nasal decongestions, and immunosuppressive medication can cause hypertension, such as cyclosporine. Anti-angiotensin therapies can cause also hypertension. Should be monitoring the patient who are using these drugs. Other drugs and substances that may raise hypertension: anabolic steroids, erythropoietin, non-steroidal anti-inflammatory drugs, and herbal remedies. Regarding home take messages, patient characteristics that should raise the suspicion of secondary hypertension are the following: younger patients, less than 40, with grade 2 hypertension, or the onset of any grade of hypertension in childhood, acute worsening hypertension, a patient with previously documented chronically stable normotension, renal resistant hypertension, severe grade 3 hypertension or hypertension emergency, clinical or biochemical features suggestive of endocrine cause of hypertension or chronic kidney disease, clinical features suggestive of obstructive sleep apnea, symptoms suggestive of pheochromocytoma or family history of pheochromocytoma. Thank you.
Thank you very much. Thank you. Don't forget that the most important also cause of medication-induced hypertension is non-steroidal anti-inflammatory medications.
I mentioned it. It's here.
We write it by itself. It's very important. Thank you very much. It's an excellent presentation. Excellent. Thank you.
Thank you.
Presentation is speaking about a 20-year-old male patient with no past medical history. He presented with a headache. All vital signs has been recorded, like his blood pressure was 160 over 100, and the ECG showed a criteria of LVH. For sure, we did a CT brain for other routine imaging, and it was normal. Full routine labs also was in normal ranges. So patient was referred for an endocrinology consultation, and labs of endocrinology disorder and imaging showed that all was in normal average. Patient after 1 week come back to the clinic with the same complaint, with no change of the headache intensity. And for sure, we did an echo, and the echo showed after we did echo, we have a cardiology consultation. From this brief presentation, I'd like to ask a question about what do you think of the criteria of this ECG? It's a very simple one. What do you think? It's a suspicion of LVH or aortic stenosis or hyperacute T wave abnormalities? Yeah, it shows the criteria of LVH. If we calculate the amplitude of 1v6 will be more than 35. So it's a criteria of LVH. We did a physical examination, and the typical physical examination finding include a strong pulse and hypertension in the upper extremities, diminished or delayed femoral pulses, and the blood pressure gradient, low or unobtained arterial blood pressure in the lower limbs, chest auscultation. There was a murmur on the back of the chest. Cardiac auscultation, no specific finding, and abdominal lax, lower limb, no specific signs except the faint pulse of the lower limbs. So this is an image of echo finding, which as you see, suprasternal imaging showing the aortic arch. This is the arch of the aorta, and the part of the descending showing a stenotic part, and we did a continuous Doppler, which showed a significant stenosis, and the gradient is more than 4. Sometimes we couldn't see this the high gradient on this area because of the peripheral circulation in this area can make the blood to be diffused away. So it is not also always to see this gradient. So for sure we go for the second image for the diagnosis, and we did a CT orthography. And this is a CT orthography has been ordered and is showing the following data. What do you see? What do you see of this CT orthography? As you see, the arrows here showing a stenotic part in the site of the communication here in the descending aorta. So it is highly suspected of coarctation of the aorta. Another question here: what is the most common site of aortic coarctation? Is proximal to subclavian, is distal to subclavian artery, or in thoracic aorta?
Sam, are you there?
Hello?
To distal to subclavian artery.
Okay. Yeah, this is right. Usually, the most common site, it can occur at any site of the aorta, even in the thoracic aorta, but the most common site is beyond the subclavian artery. This is a diagram of trying to illustrate the hypertension, and we also know that we have a primary hypertension or essential hypertension, which represent 95% of cases. The age varies from 20 to 50, even if it was suspicion of a positive family history and no features suspicion of secondary hypertension. The secondary hypertension, it is represent a 5%, but it's very important to go for the differentiation of the secondary hypertension. Usually, at the age from 20 and less than 50, no positive family history of hypertension and no any history of hypertensive urgency or resistance hypertension, and patient without any positive medical history. So we suspect of secondary hypertension. We should differentiate between it is renal cause or a mechanical cause or endocrinological cause. Sometimes maybe an exogenous causes like corticosteroid drugs or oral contraceptive pills, cocaine, or any of medications that can cause the secondary hypertension. And we all mentioned that secondary hypertension can be also related to renal artery diseases like or renal parenchyma and patient with CKD or AKI or glomerulonephritis. The renovascular disease also can be secondary cause in unilateral or bilateral renal artery stenosis. A mechanical cause, like our cases here, is like aortic coarctation or obstructive sleep apnea. The endocrinological cause is too much, and we should, if we suspected a case of secondary hypertension related to an endocrinology cause, we should refer the patient to know the main cause of the hypertension, like a glucocorticoid excess in Cushing syndrome or in pheochromocytoma, mineralocorticoid excess in primary hyperaldosteronism, or hyperthyroidism, mainly the systolic hypertension, which be high, and hypothyroidism mainly be in the diastolic hypertension, or hyperparathyroidism. Pregnancy also, as we know that gestational hypertension, it can be one of the causes in the secondary hypertension. Intervention in coarctation of the aorta. As we know, coarctation of the aorta, if it is suspected clinically, we go for the imaging like echo, and then we go for a CT. But from the clinical presentation in non-invasive pressure difference more than 20 between the upper and lower extremities, but with upper limb hypertension more than 140/90 in adults, or abnormal blood pressure response during exercise, or significant left ventricular hypertrophy from the ECG or an echo, it is class 1 indication for intervention. But in patient independent of pressure gradient, hypertensive patient with more than 50% of the aortic narrowing relative to the aortic diameter, it is also can be for intervention as a class 2A. This is a brief presentation of coarctation of the aorta. One thing I want to mention is that because I have seen this case before, the patient was suspected of coarctation of aorta and was no gradient in the stenotic site. And we go for the CT aortography, and the patient was diagnosed with coarctation of the aorta. I tried to know the cause of why there is no gradient on the stenotic side, and I find that the peripheral circulation there prevented the congestion and making the blood to move away, so that it's not always to see this sign of coarctation of the aorta by echo. So it's if you suspect it is by clinical, we should go for more investigation so that not be missing. Thank you.
Thank you. Dr. Ahmed.
Very interesting, actually. Coarctation of the aorta is not uncommon. The thing about the pressure gradient, sometimes you see a significant coarctation of the aorta and you do not see a pressure gradient, usually because it's well collateralized pre and post the stenosis. And I've seen from our structural fellows, our team in Shams, of course, it depends the management on so many things, but the gradient is probably the most important. And it's a very big problem when the patient is young, because any stenting will cause a problem later on, because it will be undersized when the child grows or the infant grows later on. So usually they start with a dilatation just to make the flow go ahead. Surgery is always there, but newer stents and other things, coarctation is not uncommon. It should be really extensively looked, and do not forget to do the suprasternal echo views, because you might miss coarctation. And usually it comes with bicuspid aortic valve, because there is usually a multi-level of stenosis. So always think of bicuspid aortic valve with the coarctation of the aorta. They might be present in both cases.
Okay, to introduce the case, it's a 20-year-old male patient with no past medical history. The chief complaint was a headache. Blood pressure was 60/10. ECG showed criteria of left ventricular hypertrophy. CT brain was normal, and full routine labs was with no in normal range. Patient was referred for an endocrinology consultation, and labs of endocrinology disorders and images was within normal. So the patient, after 1 week, came back to the clinic with the same complaint, with no change of headache intensity. On physical examination, he was eupneic, same blood pressure, heart rate at 60 beat per minute, strong pulses in the upper extremities, diminished femoral pulses, and a blood pressure gradient between upper and lower extremities. At chest auscultations, where we had interscapular murmur. On ECG, regular rhythm at 65 beat per minute. Left ventricular hypertrophy. We had a sacral index at 60 millimeter and a coronal index at 29 millimeter. On lab tests, he had normal hemoglobin level, normal renal function and troponin levels, normal potassium and calcium levels, and no biological inflammatory syndrome. Echocardiography study in suprasternal view showed on color Doppler imaging illustrated flow turbulence at the location of the descending aorta segment, with an increase in the peak Doppler velocity from the proximal aortic segment to the segment below the site of the probable aortic coarctation. So for a differential diagnosis in hypertension with a patient at 20 years old male, we have to think about secondary hypertension. So for exogenous corticosteroids, cocaine, other medication, the patient wasn't taking any medication, renal parenchymal disease, but normal kidney function and normal potassium level. Renovascular disease, he had normal renal Doppler. Endocrine causes like Cushing syndrome, but normal potassium levels, normal physical exam. Pheochromocytoma, he had negative Menard steroids in clinical exam. And we have to think finally about mechanical causes like aortic coarctation. It's the most likely diagnosis based on physical exam and echocardiography findings. So we went to CT aortography to confirm the diagnosis. We have to think about associated lesions. So it include bicuspid aortic valve up to 25%, ascending aortic aneurysm, subaortic stenosis, or supraaortic stenosis, supramitral valve stenosis, including parachute mitral valve. It was eliminated by echocardiography and CT. Extracardiac vascular anomalies, including anomalous origin of the right subclavian arteria in 45%, or collateral arterial circulation. It was eliminated by CT. Intracerebral aneurysm in up to 10% of cases, but imaging of intracerebral vessels is indicated in the case of symptoms and or clinical manifestation of aneurysm or rupture. For the treatment, it's an indication for an intervention in all patients with a non-invasive pressure difference below more than 20 millimeter between upper and lower limb is the case of our patient. If we don't have hypertension, it's indicated with class 2A if hypertensive patient with more than 50% aortic narrowing relative to the aortic diameter at the diaphragm level. So for the prognosis, most frequent complications are recurrent coarctation. Recurring or residual coarctation may induce or aggravate systemic arterial hypertension and its complications. Aortic aneurysm, aneurysm of the ascending aorta or at the intervention site present risk of rupture and death. Hypertension, medical treatment of arterial hypertension should follow the hypertension guidelines. Cerebral aneurysms, cardiomyopathy, paralysis, but the risk of postoperative paraplegia can be reduced with mild hypothermia and post-coarctectomy syndrome. For the follow-up, all patients have to have a regular follow-up at least every year. Imaging of the aorta, preferably with a CMR, is required to document post-repair or post-interventional anatomy and complications like restenosis, aneurysms, fault aneurysms formation. Recommended imaging intervals are commonly every 3 to 5 years, but also depend on baseline pathology. For exercise and sports, patients without residual obstruction who are normotensive at rest and with exercise can usually lead in normally active lives without restriction. But for patients with arterial hypertension, residual obstruction, or other complications, they should avoid heavy isometric exercises in proportion to the severity of the problem. And thank you very much.
Thank you. Excellent review. Excellent case presentation. Excellent review. Really no comments. Thank you so much, Dr. Anu. Thank you so much.
Excellent case analysis.